Hey everybody, this is Todd from Beyond Type 1. It is April 29th at 11:34 a.m. and we are once again joined by our favorite endocrinologist, Ann Peters from the University of Southern California, to talk about everything new with coronavirus, with COVID-19. And Ann, I guess just right off the bat, I do have a question for you. I think in our first interview, you introduced yourself as a diabetologist. And I'm curious, what is the difference between a diabetologist and an endocrinologist? Or is there a difference? What does diabetologist mean?
Well, a diabetologist is a made-up term, and it doesn't exist. But this is the problem, is that endocrinology is all the hormones. And there's a subset of us, and very small, because most people who go into endocrine don't want to do diabetes, frankly, because diabetes takes a lot more time than thyroid. So there's a small cohort of us who have eliminated most of the non-diabetes stuff. I don't do anything but diabetes. And I want to be recognized as somebody who is that focused. So I use the term diabetologist when I'm talking to an audience like this to let you know that that's all I want to know about. And when I'm doing it publicly, I have to be an endocrinologist because that's what I am. But I actually was on the board, the endocrine board, and I tried to get them to just give us our own little baby subspecialty. But I'm still an endocrinologist, but don't tell anyone.
So diabetologist is like a subset of endocrinology, but focusing just mostly or all on diabetes.
Right, and it's one that we made up. But I don't care because I think people need to know that I care about diabetes, because you don't want to go to somebody who just sees you as an afterthought. You want somebody who thinks of diabetes as the headline. And there are really not enough of us, and that's why it's a community, right? Because it's a community of educators and everybody who cares about people with type 1. So I want diabetologist doesn't have to be a doctor, just FYI. It's everybody.
Great. Okay. So now let's shift back to coronavirus, what we're here to talk about today. I think in the news lately is a lot of states are recently announcing that they're going to lift their shelter in place. Not where I am in California. We just extended to the month of May. I realize you're in California also, but some of the states in the middle of the country, I think as soon as Friday, are going to be lifting their shelter in place. For people with diabetes who are living in states that might be opening everything up, opening stores and going back to kind of life as before, what would you recommend? Should they take extra precautions because they have diabetes? Or I guess, how would you advise people in those areas?
Well, so this is the deal. I think that as Dr. Fauci has said, it's the virus that tells us what's going to happen next, not us. And so people have decided to open up, but I don't know that that means it's safe to open up. I do know one thing for sure, which is that I still can't predict this virus. So most people get mild disease, some people get moderate disease, and obviously some people die. And I think what happens now as states open up is it becomes a personal decision. And as I've always said with type 1 diabetes, it's all about managing the risk related to diabetes, staying out of the hospital and everything else. And that if you're young, healthy, and have a good A1C, you're likely to be fine if you get COVID-19. And a lot of people are going to get COVID-19 as we open up more and more. But it means that we have to say, what's our level of risk? And so we were actually joking beforehand about the fact that I'm going to dye my hair blue. And it's actually because I have decided on my own that, I've gone in to get my hair colored every month for, ever. And even when the restrictions open and I can go back and get my hair done, I'm not going to want to go to a place which is a closed room with a bunch of people and risk it. And I'll go every 3 months and get my hair cut, but I won't go every month. And so I'll deal with my hair color however I decide to. But the point is that that's my choice. My choice is to limit access in this way. Will I always wear a mask to the grocery store? Yes. Will I go into a restaurant? No. What can I do personally to define my risk? Will I go work in East Los Angeles in a clinic where I could get exposed? Yes, because that's something that I believe is worth the risk. But I think that that's the point. And every parent with kids, as schools open up, then you're going to have to say, well, I could get this from my child. What's important to me? Is it important that my kid go to school and I bear some risk and assume that if I get it, it will be mild? And then there's the other step is, how do I protect older people from this, the grandparents, people who might not do as well. So in every state where it's opening up, it doesn't mean that the virus is gone, and it doesn't mean that it's okay for an individual to get it per se, but we still look at risk profiles and then determine, what an individual should do. So it becomes about individual risk assessment.
I see. And you said that we were joking about you dyeing your hair blue, but I didn't take it as a joke. I'm expecting to see you with blue hair.
It will be blue the next time you all see me, or orange if I blow it. But I also think that there's this whole fallacy out there about antibody testing. And everybody seems to think that we can test for antibodies and figure out who's safe and who isn't. And the bottom line is there is no antibody test that's currently commercially available that tells you if you're safe from COVID because you've had it. It's very, very tricky to do those tests, and the FDA is scrambling. But the bottom line is don't go for a test unless you want to discard the results. If a test is negative, though, if it says you haven't been exposed, then that's probably correct. It's the ones that tell you that you have that become much more confusing. We don't know what an antibody means. Is it an antibody to a different coronavirus that's not so bad? Is it junk in the assay? Do you really have it but don't have it picked up on the test? It's very complicated, the testing. So don't think you can get a test yet for the antibodies. You can get a test for coronavirus, but not for the antibodies.
You have any sense or inclination of when that reliable antibody test might be available?
Probably maybe in end of May, June, but we don't know. It's going to take us a while. And you can even get an antibody test through Quest or LabCorp, like a legitimate place, which is actually not a validated antibody test. And if you read the fine print, it says on the test site, it says, well, this really isn't meant to tell you whether or not you've had COVID-19, even though the test says it does. So it's not even just that the media is misleading us. It's actually that you think you can get a test, and yet it isn't yet validated or accurate. So I think everybody just needs to wait about this. So everybody keeps thinking, I think it's a great idea, but we have to wait till we know more. This is not an epidemic we've had out there for very long. Science is going as fast as it can, but there's a huge number of variables that goes into making a test useful, especially in this kind of process where it's actually at a very low level in the population as opposed to a high level.
I see. I did want to ask you about telehealth, and I'm really interested in how coronavirus has kind of sped up the adoption of telehealth and forced people's hands in a lot of way. And I'm wondering how you made that transition. Were you doing any telehealth before this? How much are you doing now? What was that transition process like? And then I'd love to get your thoughts on if you think this will kind of become the new normal, or if there's been some sort of paradigm shift that even were there to be a vaccine, were there to be no coronavirus at all, we're now in a world where telehealth will become more of the norm.
Well, as usual, I'll give you about 6 different answers to one question. But first of all, this is the thing about telehealth. In general, people aren't used to it. And I've been doing telehealth before the COVID problem happened, but I hadn't done a lot of it because you don't get reimbursed. My notion is that people with diabetes don't need to come see me nearly as often as you would if you had a sore throat and didn't have your throat looked at. It's a much different process than acute medical care. And I've always believed in telehealth. And the way I got to be able to do it very quickly is not only did I have the infrastructure because I had the platform and I knew how to bill and do all the other stuff, is that my staff has been so helpful that they contact the patients the day before and get them to know how to upload their devices if they haven't done it or they can't find the cable or whatever, so that when I talk to somebody, I have immediately available all the data on that person. And so you can't do telehealth if I can't see the data, whether it's from your meter or your pump or your CGM or all of the above. So I need data just like in the office. And if I can't do data plus telehealth, I can't do telehealth. So I have an article coming out this week in diabetes treatment, diabetes therapy, diabetes technology and therapeutics. And basically we've shifted to telehealth in East Los Angeles, my underserved population. And it's not telehealth like seeing somebody, it's just telephone telehealth. And what it's done, I think, is really increase access to care, because in the past, people would have to take 3 buses to get to our clinic, or they'd have to find childcare, they'd have to miss their job for a day. And now in those underserved clinics, I can reach patients easier. And it's my fellows who do all the outreach. And I hear things that I've never heard before, like we do an insulin dose adjustment and then they say, well, we'll contact you again in 2 weeks. Like that never happened before. It was like a 3-month thing till we actually got to see the patients again. So what I'm finding is that the telemedicine approach in people's lives where their lives are even busier than mine or harder to take a break from healthcare, is very helpful. And our no-show rate is only 9%. It means that most of the patients are doing their telehealth appointments, whereas they used to often not show up to clinic. And coupled with telehealth, our clinics in LA County we used to make people come in every month to get their supplies like their insulin, and we could only give them a couple months worth prescriptions. And now we've given them a year's worth of prescriptions and 3 months stuff is shipped to them. So not only have we increased access to medications, we've increased access to the doctors. So we're basically in LA County, which is this big county hospital where we often see ketoacidosis, we're not seeing it because we're taking care of patients better. So I actually think about telehealth as a way that I can outreach to people that maybe couldn't have so easily connected. And that's huge. But the thing that my underserved patients lack is computers, so they can't upload devices, and they also lack devices. So I can't get the data that I can from my patients who have all this connectivity. So my current push is to get patients to get more access to devices so I can look at the data, because with a CGM and a patient, I can do anything on telehealth, but I've got to have the pieces, I think, to make it happen.
What is like a normal no-show rate? If it's 9% now, what was it back when it was all or mostly in-office appointments?
Probably, well, I mean, it's been as high as 50%, but I think it's closer to like 20 to 30% at baseline. But you know, it would just be so disappointing to me. I mean, it's not like I took it as a personal issue, but that when patients who really needed us wouldn't show up for a year. You know, to me, that's just, there are many, many reasons that would happen. But to me, these people who need me the most didn't come. It's like in my patients who have easier lives, who are more affluent, it's easier to take off work. People don't realize how hard it is if you're working and just getting paid hourly to miss a day of work. That's a big deal. So one of the caveats, though, is that everybody's home right now, and it's easier to reach them on the phone. When they're actually at work, it might become harder again, but they have to have breaks, or supposed to have breaks. But at any rate, my point is I always see a plus side. So my plus side to telehealth is it may make it easier for me to reach patients, for all of us to reach patients in their homes in a way that we can communicate. With technology, it may make it so that I can do visits, you know, often this way because I can do the same kind of thing. But I still believe that there has to be an interspersing of in-person visits. So whether it's once a year so I can look at people's feet and their infusion sites and, you know, feel their thyroid. I mean, I think once a year there has to be some sort of physical, you know, interface with the provider. But a lot of the in-between stuff, I think, can be telehealth, but it's also a preference, right? So if you prefer to see me in person, it's fine. If you prefer to see me I'd love to give you the option, you know, which do you prefer? It's not up to me. I can give you medical care, however, but I need your role in this, your choice has to be part of it.
Got it. And so you mentioned, I think that DKA might have even gone down among some of your patients. I did want to ask you about, I think that I've seen some reports, I don't remember exactly where, and people have been talking about high incidences of DKA amongst people with type 2 diabetes who have gotten coronavirus, and maybe even some incidences of like severe insulin resistance for people in the hospital. Can you give me any more background on that?
Well, we have seen cases even at LA County of type 2s who've gone into DKA with COVID. And it may be, I don't know why, but it may be because in a couple of those cases, it's because they were put on high doses of steroids for the COVID. But we don't have enough inpatient data that's at least been published to know what happens. In my patient population, I haven't had anyone go into the hospital, but my type 2s have actually when I've watched them, have actually shown a reduction in blood glucose levels because they're eating so much less because they're sick. And that's a problem with type 1s, obviously, because people with type 1 diabetes have to eat and dose insulin. But I don't think we have enough inpatient data, at least available. But I have seen type 2s go into DKA, and one of them was on an SGLT2 inhibitor. I mean, they're complicated reasons, but I've seen DKA in type 2s that have been inpatients. So I agree it's a phenomena, but all of the reasons why are complicated.
I see. Is there anything else new since I talked to you 2 weeks ago? Like, what about our understanding of how COVID-19 makes you sick? I think there's been some kind of developments there. Do you know anything about that?
Well, I think we don't know any more than we knew 2 weeks ago. In fact, I think that maybe we know less.
Yeah.
But I mean, what things that are really bothersome are that we've learned that there seems to be certain things that are concerning. There are higher rates in African Americans. There are higher rates in Latino individuals, especially younger. Obesity itself, I think we talked about, is an independent risk factor. And we're seeing more strokes in younger people. And, you know, that's kind of out of the blue. Like, why should we be seeing strokes with this? And it's both an autoimmune process, but there's also this vascular blood clotting stroke problem. And I think that the biggest issue is, why do certain people get these horrible complications from the same virus that in most people is mild or moderate? You know, I don't understand these really severe cases, and nobody does. What makes that risk there? And then how do we prevent it? And there was just data this morning that this drug called remdesivir is a drug that they've been testing. It's an antiviral. And they stopped the trial earlier because, and you've got to know research to know that there's the devil's in the details. They did a research trial in which they took patients who were already intubated, who were already in the ICU, and they gave them the drug versus the placebo. And in the patients who got the drug, they got better in 11 days versus the people who were on placebo who got better in 15 days. So you get better 4 days faster. But, and none of us have seen the data, but my belief is it doesn't reduce your risk of dying, because they would have said that, but we'll find this out. And the other news that we all want to know is, does it prevent you from needing to be intubated in the ICU? Because they're only treating the sickest people. So it may be helpful for the sickest people to stay less time in the ICU. But as a clinician, I still want a tool to give you or me to not end us up in the ICU. And those are the trials that are much harder to do, because when you take less sick people, you've got to follow more of them to see how many will get actually sick and whether the drug matters. So I think it's good news in some ways. It does do something to shorten the duration of the time you're in the ICU, but our first choice is still preventing the whole severe process to begin with, and that's not what we have.
Right. Okay. And then the last question, it's one that we've actually gotten a few times. I don't know that you'll have a good answer for it, but maybe you can just explain to us a little bit of how viruses can trigger type 1 diabetes. People are asking, do we think the coronavirus might trigger diabetes in people, in type 1 in people? Like, could there be actually an increase down the line of incidences of type 1 diabetes as a result of there being this new virus out there?
Well, that's a very good question. And it's a very odd answer, because the answer I probably gave you last time is different from the one I'm giving you now. Is that in January and February, I saw this really weird cluster of adults getting new onset type 1. And I only know this because I'm not part of a big hospital, so people tend to refer people to me, or they somehow find me from the ether, right? People just come to see me. And all of a sudden, in January and February, I had all of these new onset type 1 people who were between the age of 19 and 45. But like every week, somebody who'd been really, really sick in the hospital was getting new onset type 1. And I was like, what is happening? I've never seen rates of type 1 diabetes like this. And so I actually started doing tests for viruses to see if there was some virus out there that had caused this in my patients. And all the tests, which didn't include anything for COVID-19 because we didn't know about it really, it was just in China, came back negative. But what it makes me wonder is if there was some early, COVID that did this, but we haven't seen it since. I haven't been seeing lots of patients with new onset type 1, which you'd think would be happening now that we have more of it. So my answer is it makes me wonder, and it is certainly not a known diabetogenic virus, but since we know so little about it, maybe it has some role, but we just don't know. And there's nothing to do to prevent or treat it. So it's, an unknown. But I do wonder about this because survivors of the 1918 flu pandemic had much, much later an increased risk for Parkinson's. And we don't know what our exposure to this now means 20, 30, 40, 50 years in the future. So again, it begs the point of all of us should really not get it if we can avoid it. And as things open up, we just need to be careful. But again, I think that we're going to see more and more people getting it. And it's just going to happen because things are opening up. And if hopefully we don't overwhelm the healthcare system, it'll be okay. But we will see more and more cases. It's inevitable. And the concern is that maybe if it's better in the summer, it will come back again in the fall, even worse. It's not like it goes away, but that it will be more, we'll see more cases. So I tell people that I predicted a pandemic a long time ago. I've been prepared for years. Because if you knew anything about viruses, you knew we were going to have a pandemic. And I could always imagine a pandemic starting. And I could always imagine a pandemic ending, which is when we find a treatment and a vaccine and then everybody's fine. But I never imagined the middle. And now we're in the middle. And I don't know what to imagine. I'm like, what's going to happen here? What's our life going to look like? What's it going to look like this summer? What's going to look like this fall? I never imagined a middle of the pandemic. So we're all kind of in this together going, whoa, what does this look like? So I'm just pointing out the middle is the hard part, and that's what we're in now.
Great. Yeah. Well, if your answer for that question might have been different 2 weeks ago, then I'll make sure to ask you again next time we chat.
Yes, absolutely.
I think that was it for me. Is there anything else you're thinking of or interested in, or anything else new coronavirus that you think we should talk about that we haven't touched on?
No, I think we're doing pretty well. I think that mostly the key is to follow the science. And it's very hard to do it because, I spent my life reading research articles and talking to scientists and, doing my own clinical science, but it's easy to want to hear an answer. It's easy to want to make this simple. And I can tell you that this isn't simple. And I can tell you that this is the most complicated virus that I've ever seen in terms of how it affects human beings. And it's, it's fascinating, but I would prefer it not to be something we're living through. But we will get treatments, we will get a vaccine, and we will get testing, but none of that's really here yet. We're little hints of things, but not really here yet. So just be safe, take good care of your diabetes, and that's the best we can all do. And exercise. Everyone has to exercise because of this lung thing. I do think that it's good, just to keep our lungs happy and healthy. So, plan exercise time every day. I think that's a really good thing.
Absolutely. I walked 14 miles on Saturday. I walked across the Golden Gate Bridge and back. I think it's the farthest I've ever walked in my life.
Did you have good footwear?
I think my running shoes are a little old. I need to replace them. It was good for the first 3 hours, but the last hour my feet were a little sore.
That might be overkill. So that's another thing I tell people. Don't overdo it. You got to watch out. You're young and healthy, but I'm just saying, you just really need to make sure you don't get hurt. The worst thing right now is to get something injured. And I don't think you got injured, but just be careful. I have friends who walk around, and one of my friends just said that he looked down and he'd walk 20 miles. I mean, people are just wandering. I'm like, well, okay, whatever. But no, get exercise. I just think that I can't stress that enough. And, make sure you don't go low afterward. That's key also, but do all those right diabetes things.
Yep. All right. Well, thanks so much. And always a pleasure. And we'll talk to you again soon.
All right. I'll talk to you soon. Take care. Okay. Bye.